discussion is about heel rise assessment and some important things to look for in Achilles tendinopathy. So the questions we're going to answer are why and how do people compensate during a heel rise? What loading is reasonable to require from rehabilitation for the triceps surae plantar flexors? And what loading causes remodeling of non-insertional Achilles tendinopathy? And what loading is important to control for insertional Achilles tendinopathy? So here we have two free body diagrams with a person kind of overlaid on it. During the heel rise task, here's the peak heel rise height to the left and the midpoint of a heel rise to the right. At first, we notice that the internal moments generated by the force of the triceps surae stay relatively the same throughout the task, meaning that the moment arm is the same and the force generated to lift body weight is relatively similar, because acceleration of the body isn't happening that quickly. Then we also notice, though, the red, which is the external moment, is varying, where the external moment is actually less at peak heel rise height as compared to the midpoint. Now, what's also happening, though, at the peak heel rise height is that the ability of the triceps surae to generate force is compromised by the shortening length of the muscle. So what happens when someone's trying to compensate and they can't get their heel off the ground, what they might do is bend their knee. So by bending their knee, they're going to dorsiflex their ankle, recruit the paralleloelastic element of the soleus muscle, and use that to leverage their ankle off the floor. So that's reviewed here in this graph, or this slide. Now the next question is, what loading is reasonable during rehabilitation? And you might recall that the PCSA, or the physiologic cross-sectional area of the soleus, is the largest in the body. And as a consequence, it's able to generate large amounts of force and torque at the ankle joint. And we see that reflected here in moment graphs and during walking and running. And so the initial point here is the initial contact during walking, and then this 0 point here, when it returns to 0, that's toe off during that same site. We have the same graph here for running. And we notice this is Newton meters per kilogram. And so the peak ankle plantar flexion moment is around 2 Newton meters per kilogram for walking and 3 Newton meters per kilogram for running, which corresponds to a plantar flexion pounds of force on a weight machine of nearly 400 for a 77 kilogram or a 170 pound man. So in order to get to adequate loads that help people meet the needs of walking and running, we need them to be generating 2 to 3 Newton meters per kilogram to get to a training dosage that equals function. So it's much higher than we normally think. The second is is there actually an advantage to eccentrics? So typically eccentrics are done just from a standing position with body weight. I think we want to ask ourselves, does that really tap into a potential advantage of doing eccentrics? So this is a force length, a force velocity curve where concentric contractions are represented on the right and eccentrics to the left of this midline, which is the isometric contraction point. So if we're only working concentrics, or as high as they can get with a concentric contraction, we're only working in this range to the right, which doesn't tap into this higher ability of the muscle to load, take on load, or achieve forces during an eccentric contraction. So one approach to getting high load dosages or overloading the tendon when training requires that is to raise up with a very, very high weight, meaning their peak maximal isometric or near maximum concentric load using both feet. So they would be exceeding the load they could concentrically produce with one leg. And so what we'd be doing is pushing them into this higher eccentric loading and then having them lower that exceedingly high weight with one leg. So up with 2, down with 1. But the key is the up with 2 has to be more than they can concentrically contract with one leg in order to hit this eccentric loading zone. So by using that technique, it's possible to load the tendon much more than you would doing just concentric exercises. So the first thing we're going to talk about is apply this to is non-insertional tendinopathy. It's mostly acquired in runners, and it's noted by a large nodule in the tendon, which is shown here. So just to orient you for a minute, this is the tibia, here's the talus, this is the calcaneus, so the ankle joint, the subtalar joint, and then here we see the tendon Achilles traversing superiorly. This large nodule is abnormal. The tendon should be much thinner, looking like this distal part down here. So with heavy load eccentric training that hits the eccentric zone, and in this particular person achieved a peak training load of 400 pounds, which equates to, for a 77 kilogram person, it would equate to 3 Newton meters per kilogram. They were able to cause tendon remodeling that moved their tendon from this girth shown here to the left. We can see the wide girth on the ultrasound image here to the more normal looking girth to the right. That was approximately a 30% decrease in tendon girth. And so achieving an adequate training load may be a critical factor for remodeling tendon pathology. So another issue is how to control pressure for insertional tendinopathy. So let's first talk about insertional tendinopathy and then locate where the pressure is occurring and how. So this is also an MRI image, and what we see in insertional tendinopathy is it's really a trifecta of 3 things: tendinopathy, bony deformity, and retrocalcaneal bursitis. And so here we see an MRI that shows the tibia, the talus again. Here we see the calcaneus. And so here's the ankle joint, subtalar joint here. And then we see the tendon coming down, which is much more normal proximal, but now we see distally where the arrows are shown. Well, first we see a bright white spot on the bone, looks like it's coming back there and hitting the tendon, and then where the insertion is, the tendon's discolored. So what this would be is tendinopathy, the area of the insertion where it's discolored. There's some retrocalcaneal bursitis, and we see that in the whitened area. And the shape of the calcaneus itself is pointy or sharp, approximating the Achilles tendon, which means there's potential for the bony tendon to dig into the tendon when the person dorsiflexes. So this was examined in people with IAT using this ultrasound elastography, and what we see here is a person standing, and they're evaluating. They're using an air bladder to move the foot into dorsiflexion, plantar flexion, and neutral while they take ultrasound images. And what they're essentially doing is modeling this portion of the tendon that approximates the calcaneus to determine the amount of stress or strain that's in that individual area of the tendon. And we can see the maps, the tendon maps, and their pressure images here for the superficial, the deep, and then the outline of the calcaneus here. These are for the different positions. And they've also done testing of this with tissue extracted from the people that had insertional Achilles tendinopathy. And what we notice is that people with Achilles tendinopathy that have this trifecta of retrocalcaneal bursitis, bony abnormality, and this increased pressure on the deep side of the tendon, what they're experiencing is increased tendon stiffness. And we see that reflected was both in the elastography, the previous experiment, and then this experiment here where there's zero strain is this peak point on the graph. And so we see the IAT in red, which deforms less, which means if it deforms less, it's more stiff than the blue, which is a normal tendon. And we hear a stress strain curve here where we see in red the IAT, which is deforming less for a given amount of stress. And so that means it's more stiff than the blue, which is the control. And so the idea is that what's happening is the tendon's getting a lot of compression at the calcaneus, which is causing it to differentiate, undergo metaplasia, and differentiate into cartilage-like tissue, which ultimately can express itself as calcium deposits in the tendon. But this is a fairly significant and painful condition. And so one of the key activities you're going to do in therapy is decrease that compression. And so one of the things you do is use heel lifts, and then represented here by the nice looking boots from Texas, which you can see they put the foot in a plantar flex position and lift the heel off the floor. The other thing is to avoid activities which require a significant amount of dorsiflexion, like stairs. So you would do those one step at a time just to decrease that compression that's occurring for significant patients. Squats and hills would also be off limits. And then when you're doing a tendon remodeling exercise, because you'll still do the same exercises you do with patients for non-insertional tendinopathy to cause the tendon remodel, during those exercises you would want to make sure the person was not utilizing their dorsiflexion range. So you just have them do the heavy resistance exercises to a neutral dorsiflexion position to try to minimize the amount of compression about where the calcaneus would meet the Achilles tendon. And then finally, a significant number of individuals with insertional Achilles tendinopathy require surgery. Approximately half of them go on to surgery, and this would be what the surgery would look like. You can tell it's clearly focused on relieving the compression that's occurring between the tendon and the posterior calcaneus. Here's the pre-surgical bony anatomy, and then here's the post-surgical bony anatomy, and you can see that the Haglund deformity, or the prominence on the posterior aspect of the calcaneus, has been removed.